All right, well, thank you and good morning and welcome. Early start to a Saturday morning. I just wanted to start by making this a bit of a tribute to my dad who died last weekend. He was a GP in Hamilton in Hillcrest for about 30 years, and he was very involved in the Royal Australasian or Royal New Zealand College of General Practitioners and was a very enthusiastic teacher for trainee GPs. COPD is a major problem, and it's really a problem for generalists, and I'm a generalist at Auckland Hospital, and we see this as a very much multi-system disease with a number of different issues. Today's presentation is really to focus on the new approaches to inhaler therapy in COPD, and also to look specifically at how we handle really what has been an increasing number of new types of combinations of inhalers for COPD. This area, as you will see, continues to be debated vigorously at the sort of specialist level, if you like, and this is for a number of reasons, primarily based on what data is available and as it comes to hand. So just by way of disclosures, I do sometimes function on an advisory board for GSK and receive honoraria for that. Otherwise, I have no commercial links. The questions that Jim referred to look a bit like this. What is the best way to assess my COPD patient's symptoms? What are the benefits of dual bronchodilation in COPD patients that are already taking monotherapy? And how is it best to make that transition? Where do we place the newer generation medications in the context of the older, more traditional medicines that I might have spoken about 5 years ago? Where do we place inhaled corticosteroids in the management of COPD, a far more complex issue compared to, say, other respiratory disorders like asthma? And then how does one make that decision of either escalating therapy upwards or de-escalating therapy downwards? And where does triple therapy fit into this paradigm? So this is really an agenda then of this morning's presentation, the changing landscape, particularly the so-called GOLD 2017-18 recommendations. This is where the respiratory gurus around the world, primarily the USA and Europe, come together, look at the data available from clinical trials, and then provide recommendations for the rest of us to then try and adapt, adopt, and bring to our own countries. And this has relevance in New Zealand, where we have pharmac, and with that, some nuances in availability of medications. A little bit about the non-pharmacological treatment of COPD and the greater role of exercise as part of that. And then summarise with some take-home messages. So let's just start with the overview, and Jim has really made some of an introduction to this already. The figures here, as you see them, 15% of Kiwis over 45 have COPD, 200,000 people, as many as 3.5 new cases per year. And of course, smoking still a key feature in COPD, even in people who have quit as much as 20 to 30 years prior. One of the interests that I have is in the diagnosis of COPD, and it's pretty much accepted now that we both underdiagnose it and we overdiagnose it. We underdiagnose it because we are not using spirometry enough and really interrogating patients with respiratory symptoms enough to find out whether they have the very earliest stages of airflow limitation that characterises COPD. And sometimes we're calling patients with breathlessness who have smoked COPD when there may be other causes, or they have troublesome symptoms, but in fact their lung function is normal. So it's not as straightforward as it seems. Now, really, in the last few years, things have changed, and you'll have noticed this, and they've changed in a couple of key ways. One is the availability of a variety of different inhalers, but primarily combination inhalers that combine the LAMA, the long-acting muscarinic antagonist, with the LABA, the long-acting beta agonist. So this is dual bronchodilation. This is two different mechanisms providing more bang for your buck, and I'll show you data that supports that view. This was in March about 2016. And then later in that year was the recommendations updated by GOLD, the Global Initiative for Chronic Lung or Chronic Obstructive Lung Disease, where there were some, again, changes made to how we should assess patients. The biggest change there was a backing off of spirometry to direct therapy, but spirometry to establish diagnosis. And I'll explain that more in a minute. This has been provided as part of your handout, and I think it's really there because the days of the blue inhaler or the purple inhaler or the red inhaler are over. And we now have shades of green, shades of blue, and everything else in between. This is a point of confusion for patients, and even more so for doctors trying to figure out what patients are thinking they're taking, or possibly not, but at least what they have prescribed. So let's just have a look at this and just make some comments really about where things have not changed. And this is our primary goals of therapy: reducing symptoms and reducing risk. The symptoms is to relieving symptoms primarily of breathlessness, to improve people's exercise tolerance, which we know is a key factor for quality of life, and improve their overall health status. The reduction in risk really focuses primarily on a reduction in exacerbations. The recognition that exacerbations, particularly resulting in hospitalizations, are a new level of disability and concern in a patient with COPD in terms of what it represents in future mortality, morbidity, and so on. There remains the view that if we can minimize exacerbations, we can slow the progression of the disease. In terms of other features that slow progression, smoking cessation obviously features high and is top of that list, and then after that, inhaler therapies have not really shown convincingly the capacity to slow down FEV1 or lung function decline in patients. Mortality is there with an asterisk because the studies have just not shown that inhaler therapy changes mortality. And I think we have to think about what that mortality is about and how we might approach that. And I'll mention that in one of my last slides. So these are our goals of treatment. Lung function then is no longer included in the treatment classification grid, but it remains important for the diagnosis and prognosis of patients with COPD. I'll talk a little bit about where ICS or inhaled corticosteroids and LABAs fit in, a little bit about where LAMA and LABA fits in, and triple therapy, escalation and de-escalation. There's also the recognition now that COPD can be the result of two things. One is suboptimal lung function leading up to age 25, where your lung function or your lung size is maximized. And so there are a lot of people with COPD who never achieved their maximal lung function, and their decline thereafter has led them towards the clinical features of COPD. There are those that have achieved maximal lung function because they haven't been exposed in the first 25 years of life, but have an accelerated decline. So COPD is probably a mixture of these two groups of patients. And the question is how best to manage that. So then if we look then at the first part of this, which is the diagnostic aspect, why have we backed off FEV1 as a tool to gauge therapy? Well, one of the reasons is it's really hard to see what gains are made in this setting when we look at people's lung function. And this slide really changed a lot in respiratory medicine. It shows in 4 different figures how the degree of lung function shown on the horizontal axis is so poorly correlated with patient-directed outcomes. Their breathlessness score for their MRC on the top left, the 6-minute walk test in the bottom left. These are means of measuring patient disability from their disease. The St. George's Respiratory Questionnaire on the top right, and then even exacerbation frequency, none of these correlate with the FEV1. So we really, on the basis of this, are left with symptoms and exacerbation history as our primary drivers for treatment and escalation of treatment. And so what was presented to the respiratory community back in 2011 as a grid, a 4-way quadrant with 3 parameters. Shown here, you can see the lung function on this side, the symptom score here, and then over here, the exacerbation risk, sort of 3 factors into a 2D structure, never really fit anyway. It's been abandoned now and simplified to just really symptoms shown on the bottom here, and then the exacerbations. This is in terms of identifying where your patient may be found and which treatment options would be best for them. So just to recap, diagnosis critical, spirometry critical, useful then to distinguish the basis of breathlessness in your patients, remembering that there's a lot of chest infections, what you'd think is otherwise simple chest infections as the initiating presentation, where spirometry will help identify those people with marginally impaired lung function and those in what we would describe as Gold 1 stage or grade disease, shown at the top here, whose symptoms of breathlessness are pretty subtle. And these people often have chest infections as their first presentation. This group down here with the more severe disease are more obvious, and they obviously have quite significant limitation of exercise. So, spirometry for diagnosis. So please don't stop doing that. Just by way of interest, hands up doing spirometry in your clinical practice. That's just awesome. Keep it up. Don't be put off. Don't let anybody criticize you for that. Do the best you can. It is useful data. So if we come then to the grid and how it's viewed now in 2017-18 recommendations, as I said, what you have then is a symptom score, which I'll talk about in a minute. How bad is the patient affected? And then this issue of their exacerbation history, whether it be a community-based exacerbation or a hospital-based exacerbation. So what is the best way to assess my COPD patient's symptoms? And we've talked already about the use of CAT scores, the COPD assessment test or self-assessment test, which is even better because it is able to be filled out unassisted by the patient in the waiting room. And it reflects that COPD is a lot more than just about cough and breathlessness and chest tightness. That unlike asthma, it has far more significant systemic effects involving things like activity, sleep, and energy, and with that, confidence. So it's a scoring system from 0 to 5, and scores above 10 are considered high for symptoms. When patients have exacerbations, they often go up to 25, and it's been shown in studies that their CAT scores can take up to 2 weeks to drop back to 10 or 15 or less as they improve and get to their new baseline. So the CAT score is useful in this setting, assessing symptoms and also assessing changes in therapy. Just another hands up on using CAT scores. Many people using them, just starting to. Okay. All right, well, the CAT score is available at GSK's stand, and highly recommend you use this, get familiar with it. It's something that we think is really helpful. Prior to CAT scores were the MRC breathlessness scores, and this just shows you the cutoff at which it is felt that patients have significant symptoms. On level ground, I walk slower than people of the same age because of breathlessness and have to stop for breath when walking at my own pace. We know that these are subjective. We know that people's sensation of breathlessness is very individualized. You have to work with what you got. But nonetheless, these are recognized and highly validated tools for discussing symptoms with patients with COPD. A little bit then about the changes. This is the sort of summary of those changes, and I showed you the four-way grid, the ABCD grid or quadrant, where we would assign patients in each of those four areas, and then based on whether they were patients with really little in the way of symptoms, minor symptoms, maybe just a bit of exertional breathlessness, no exacerbations, to the patient with a lot more symptoms, the patient with exacerbations as a primary issue, and then the patient who's got both. And I think where we're heading to with this, which I think does help, is a relatively simple escalation of therapy from PRN short-acting bronchodilators to mono long-acting bronchodilators to dual, plus or minus inhaled corticosteroid, and then triple therapy. And while the respiratory community debates just who and when patients should get these therapeutic options, I think the idea of an escalation of therapy and sometimes a de-escalation when it's appropriate is somewhat simplifying the story. If I go through each of these very briefly, and just to say what you have down here is the group that have the least symptoms and no exacerbations. This is the group that may come in with the chest infection, mild breathlessness. It's the sort of thing patients tend to forget or not mention instead talking about their more acute problems, whatever they may be. But this is a group we think monotherapy is useful, short-acting bronchodilators are useful, or you might consider, if the patient is having regular symptoms, a simple single long-acting monotherapy. And in New Zealand, I would recommend that this group was started on a long-acting muscarinic antagonist, a LAMA, a tiotropium, a umeclidinium, glycopyrronium. So we'll talk about some of the other names that you might be more familiar in a minute, but these are the long-acting muscarinic antagonists. The group B patients then, they have more symptoms. They escalate up to dual long-acting bronchodilators. So here the sense of it is that there isn't exacerbations as the primary basis of their disability. It's really persistent breathlessness. Moving on then to the C group, this is where exacerbations are more of a prominent feature for that patient. We see those patients in the general medical wards around New Zealand. And the question there is, do they go and transition from a monoacting LAMA, muscarinic antagonist, to a combination LABA-LAMA, or do we use the ICS-LABA combination? And of course, this has been the mainstay of our escalation normally in COPD, and now with the most recent data, you can see a stronger recommendation for the LAMA-LABA combination. So the respiratory community is saying to us, bronchodilation seems to be effective in this group, even for exacerbations, and there's some data to suggest they have anti-inflammatory effects, but again, those are all a question of research and debate. Lastly, the most severe group, it's often not a hard group to identify, a lot of symptoms, usually severe lung function, frequent exacerbations, at least one a year, or hospitalized at least once a year. And here we're looking at triple therapy on the basis of maximizing bronchodilation and maximizing the anti-inflammatory benefits that come with inhaled corticosteroid. So if we look at that and then put it into New Zealand's situation, we thought about this and have published this in the European Respiratory Journal, and it's a slight modification, but not a lot different. We introduced something called ACOS, which is not our idea. It's been floating around the respiratory world for a number of years, but has taken on a whole new interest because the clinical trials never studied this group. And this is what I've called the E group on the outside here. And these are people who have a history of asthma in their childhood or early adulthood and have gone on to get more and more irreversible disease. And of course, the question here is, how should these people who've now been diagnosed with COPD be treated? And we think, and I think most people would agree, that they're a slightly different group. And in fact, this figure was really designed based on recommendations from the Spanish, who were always very clear in their heads that there was smoking COPD and there were asthmatics who evolved into COPD, and on that basis recognized them as their own group. But they have not been part of clinical trials, and so anything like we say about this group is still the subject of ongoing research. Now, just to say, if we look then at the Group A patients and we look at this, the treatment options, we have then, as you see, a number of new inhalers of the last couple of years that are new single-dose treatments for long-acting muscarinic antagonists. There are a few issues about their use, and this is perhaps not a bad thing in the sense that these newer agents, the glycopyrronium, the umeclidinium, requiring spirometric confirmation of COPD. I think that's not a bad idea. Tiotropium are still struggling historically in the sense of having to deal with some of the earlier requirements, but also based on spirometric outcomes. So what are the benefits of dual bronchodilation for COPD patients already on a monotherapy, and what is the recommended assessment time for putting them on dual? So now we're getting to these new agents, LAMA-LABAs. Just hands up who's already been prescribing a combination LABA-LAMAs. Okay, brilliant. Okay, you're right into it. Oh, I don't need to give this talk. It seems that they've been embraced already, and that's probably a good thing. The data is very good. Again, this requirement of having patients stabilized on a long-acting muscarinic antagonist. In regards to the question being asked, how long do they have to be stabilized on a long-acting muscarinic antagonist? The answer is it cannot be found, but the best guess from the experts is somewhere in the order of 4 to 8 weeks. Okay, but this is not clearly stated in any of the documents. And so we're being asked really to consider and reassess patients, look at their symptom scores, and ask the question, can we do better from transitioning from mono to dual therapy? Are there differences between these medications? And so the answer to that is there is. This again is very much directed to FEV1 and spirometric improvement, but you can see here, for example, in the blue bar, the LAMA is superior to the LABA, and the dual combination is superior again. People debate vigorously what's the value of 50 mils, 95 mils, and so on, but it certainly shows a superior bronchodilating effect. The issue here then is whether we consider this to be a big advantage in patients with COPD, and I think the answer to that is we do. We think that maintaining airway dilatation for as long as possible to maximize opportunity to exercise as much as possible is an advantage to patients. And it makes good sense that with two different mechanisms that you might get this enhanced benefit. So the long-acting muscarinic antagonist, relaxing smooth muscle, and as opposed to the beta agonist. Okay, so you have bronchodilation then through different mechanisms for beta receptors and muscarinic receptors. This benefit from dual to monotherapy is maintained out to months and months, so that's reassuring. There's no tolerance effect, no coming together of the two graphs. So really the airways do not seem to change their responsiveness, and I think this is reassuring. And then in other more recent data in a large series of meta-analyses, again, how do LAMA and LABA treatments compare to monotherapies in this particular graph, and I'll just try and talk you through it. Everything to the right favors the LABA-LAMA, and you can see we've already talked about lung function benefits going to the right, and you can see also, indeed, for breathlessness score, the TDI is a breathlessness score, and overall health status improvements favoring this combination therapy. And I think what we take from this is that as you improve lung function, you improve exercise tolerance, and you improve quality of life. Right, are the data comparing the new bronchodilating products? And the answer is yes, we have data as well. And here again is a head-to-head comparison for the long-acting muscarinic antagonists. And again, you can see this benefit shown here with umeclidinium over tiotropium, one of our first of the market long-acting muscarinic antagonists, but now these newer agents showing a little bit of benefit here in terms of their bronchodilating effects. Also here in the combination now, the umec volanerol versus the tio combination, again seeing a similar sort of improvement for lung function. So which of my patients would benefit from an ICS? This is one of the chestnuts of respiratory medicine. How should I manage COPD patients with a previous diagnosis of asthma? And I would say that this is going to consume the respiratory community for a few more years yet. However, we again have tried to address this, and I've mentioned this briefly already in this part of the graph, and that is to say if a patient has had a past history of asthma, then inhaled corticosteroids would have been the mainstay of treatment along with a long-acting beta agonist, and it would make perfect sense to continue that and then add in a long-acting muscarinic antagonist. And as I say, studies are now being done looking at this group who have previously been excluded from the classical COPD trial. Now, in terms of the inhaler options, these more severe group, the group C, D, and E's, we're looking then, as I say, at the LAMA-LABA combination, inhaled corticosteroid LABA, with or without LAMAs in the point of triple therapy. And this is a new frontier, no doubt about that. And we're just starting to see the beginning of studies looking at triple therapy versus others. So just in terms of some of these issues, it is fair to say that in the most recent recommendations, in Gold D patients, inhaled corticosteroids and LABA as initial therapy may be first choice in patients with asthma, coexisting asthma, or a history of features suggestive of asthma COPD overlap. And these are things like childhood eczema, atopy, hay fever, and so on. And also there's a great interest now in eosinophils, blood eosinophil counts in this whole area, and I'll discuss that briefly. So what is this ACOS group, and what do we know about it at this stage? We think that it really represents around about 20% of COPD cohort that we would otherwise call COPD patients. They tend to be in the group CD, so a bit more severe, exacerbations being more of a feature. The history of asthma, atopy, allergic rhinitis, high serum eosinophilia, and very variable FEV1. You know, the classic COPD patient may have a declining FEV1 with a little bit of day-to-day variation. Those with a more asthmatic component, much more variation. So if you're measuring spirometry or peak flow, you'll pick this variation up. So the respiratory community advising us about eosinophils are truly divided on this one. There are the eosinophil guys, and there's the non-eosinophil guys. And that's just how it is. And I'm going to the American Thoracic Society meeting in May of this year, and I expect there to be a whole session on eosinophils and whether they're good or bad or useful or not. This is just one piece of data that's being used, and a lot of it has been post hoc retrospective analysis of existing data. And you see here the green bars, or the blue bars, I'm sorry, and the brown bars, where the brown bars are those that have got a combination therapy, including ICS. The blue bar patients have just got a long-acting beta agonist, and their frequency of exacerbations are going up left to right as the eosinophil count goes up. So higher exacerbation rate here versus here, and the inhaled corticosteroids presumably, despite the level of eosinophilia, producing a consistent level of exacerbations. It's only one piece of data, so lots more to come out of that story. In terms of, what do we know about inhaled corticosteroid LABA combo for exacerbations? Huge number of reviews, Cochrane reporting 25% reduction, really regardless of how you look at it, and whether you compare the ICS LABA against placebo or against LABA monotherapy. Which of my patients would benefit from an ICS? How should I manage COPD patients with a previous diagnosis of asthma? Well, we've kind of touched on that. The step-down approach, as I say, is still debated. That is, stepping down as taking a patient off inhaled corticosteroids. And anecdotally, doctors will tell me some of their patients did really badly, and within a couple of weeks or months were starting to suffer more symptoms, had exacerbations, and they were put back on inhaled corticosteroids. For others, this has been maintained without any deterioration. I would recommend you do not do step down or removal of ICS treatment in patients who have got ACOS, people who have had exacerbations or chest infections in the last year or two. And so I think you need to also be cautious about selecting these patients. On the other hand, patients that you might consider withdrawing inhaled corticosteroids are those who've had a recent pneumonia or who have consistently low blood eosinophil count. And as I say, this is still a matter of debate. Which of my COPD patients would benefit from being on triple therapy? Again, we're getting closer to the bottom line of this story. This is just to show the sort of triple benefit here now with dual bronchodilation plus the anti-inflammatory component. Indeed, for patients who are primarily symptomatic, you can see the transition then from the short-acting therapies to the long-acting monotherapy, which in New Zealand makes sense. I can't see much sense in offering a patient long-acting beta agonist as a monotherapy, given it limits your capacity to then go on and do a LABA-LAMA combo. So this is the pathway for the symptomatic patient, and the pathway for those who are symptomatic with exacerbations, the group D patients, you can see really amounts to triple therapy. Now, how you design that combination In other words, do you have a patient with a LABA-LAMA combo and a freestanding ICS or inhaled corticosteroid inhaler, or some other way of doing things is up to you. And this is a matter of convenience and delivery and so on. What do we know about triple therapy? Well, we know that the triple therapy is superior to the inhaled corticosteroid LABA combination in terms of lung function, health status, exacerbations. We know triple therapy is superior to long-acting muscarinic antagonists on their own. We don't know exactly how triple therapy stacks up against the LAMA-LABA combination. And this is where additional data will come to hand, I think, in the next 2 or 3 years. So the Gold Committee, in making these recommendations, do acknowledge that there is a lack of direct evidence for some of their recommendations for the group C/D patients. So we just wait to see where the data takes us. Be prepared for change. Okay, non-pharmacologically, just to finish off with, and not to say that this is in any way less important, in many regards more important than inhaler therapy, primarily smoking cessation, obviously. These patients are basically continuing to inflame their lungs as they smoke. Don't forget about dusty environments, which can also be adverse. We still believe vaccinations for influenza yearly, pneumococcal 5-yearly is useful in these patients in order to improve their response to infection, whether it's viral or bacterial. Pulmonary rehab are still important, but even beyond pulmonary rehab, in the patient that's in the group early stages of their COPD, regular exercise. The studies are saying more and more, and this is obviously a recurring theme in many other aspects of preventive medicine, cardiovascular world, and so on, but we're seeing more data suggesting exercise is a good thing for patients with COPD. While they may be uncomfortable with it, we provide them with inhalers to help reduce that discomfort, but have them maintain some form of exercise program, whether it's as simple as walking, step exercises, or whatever. These we feel are beneficial. And there's some good evidence that there's some anti-inflammatory benefits from that in the lung, and it avoids the vicious deconditioning cycle that goes with immobility and COPD. Diet, there's a number of studies looking at diet, and recently a study showing that the prudent diet, as opposed to the Western diet, reduces symptoms in COPD and reduces the likelihood of getting COPD. That diet is like a Mediterranean diet, and the features to look out for is modest amounts of red meat and lots of vegetables, fish, fruit, and fibre. Just some final words, if I could, on the cardiovascular story. When this work that we've been doing is part of a large collaborative study in the US involving 10,000 patients followed for a number of years, we've been interested in cardiovascular disease in this context. It kills about a quarter of patients with COPD. Lung cancer is about the same. Respiratory deaths is only about 10% for high-risk smokers and those with COPD or mild forms of COPD. So please don't forget that coronary artery disease is probably one of the single biggest killers for patients with COPD. And if you're in that preventive mindset and you're out there measuring cholesterols and blood pressures and blood sugars, another utility from spirometry is identifying a high-risk patient for a cardiovascular death. COPD is an equivalent risk for cardiovascular death as diabetes. Okay? And that's data we've just about to publish. So just coming to the end of the talk then, take-home messages. COPD treatment individualized to the assessment of symptoms and exacerbation history. FEV1 for diagnosis. LAMA monotherapy seems to be recommended by the experts and kind of fits with the New Zealand paradigm where we need it as a precursor treatment on the way to a LABA-LAMA combination. The LABA-LAMA combinations are superior to LAMA monotherapy and indeed the inhaled corticosteroid LABA combinations in certain patients. And these patients tend to be those who are asthma-like patients and with features of eosinophilia. Lastly, the triple therapy is emerging. I think it is going to be helpful for patients. We're awaiting the data, so watch the space. Thank you very much.
Thank you, Rob. I'm always amazed how you do make a broad area simple. I think that's clarified a lot of things in my own head. Questions, please.
Thank you very much for an illuminating talk. One question on spirometry. Our nurses will test before and after bronchodilation. What are the arguments for and against doing this in these cases?
Okay, well, I think the argument for doing the reversibility testing, in other words, giving a patient 4 8 puffs in a spacer and then repeating the spirometry 15 to 20 minutes later, is that you can look at not just their baseline spirometric values, their FEV 1% predicted, but their change after you've given bronchodilator. And so it gives you a sense of their reversibility. Now, while that remains a contentious research tool from a practical perspective, it should give you hope you can do better for them in the sense of making change. If that's really not convenient, I think a baseline pre-bronchodilator, in other words, without any inhaler bronchodilating therapy, is also useful in a sense of placing that patient in a group of either those with airflow limitation and somewhat obstructed airways disease, or people who have normal lung function, that you can then at least put aside and say this person doesn't have airways disease per se, and the merits of inhaler therapy and bronchodilation is questionable in that group. So I understand the difficulty of adding that extra step in. If you have the time and can do it, I think it is helpful, but I would not avoid spirometry on the basis that that was a hurdle to getting some values for lung function.
Oh, I wonder if I could ask a question. I too am very interested in the phase 1 of COPD, the early diagnosis. You've mentioned that when a person has the diagnosis, spirometry's been done, they've been completely reviewed, you've looked at the symptom burden, you've examined over the past year or two for exacerbation history. You've made the decision that monotherapy may help. Why the LAMA first? Can you be very explicit why you've chosen a LAMA first?
Okay. So the reason for that is that there is data supporting LAMA monotherapy in reducing exacerbations. There is data to suggest LAMAs are superior to LABA in bronchodilating. And lastly, Pharmac has decided that we can't progress to dual therapy unless we have started LAMA and optimized it first.
Morning. I'm just after a little bit of an extension and wondering if there are any new approaches to the management of exacerbations.
There's not. So there still remains the recommendation that we treat with a combination of prednisone. People debate 30 to 40 milligrams, 5 days. I push it out longer in some of my hospitalized patients because I think they have symptoms often out of control for a longer period and probably need more anti-inflammatory treatment. And then the decision around the use of antibiotic. And there again, there remains debate about whether the sputum is discolored and how discolored it is, and whether we should treat, if it's viral, why would you bother, but then could it become bacterial? And so I'm afraid, while I'd like to say that we had done some really interesting studies to differentiate this, the closest we have come is this debate around eosinophils and whether you can just give a patient inhaled and or oral steroids in that high eosinophilic group. But I must say my own practice is still to maintain a combined therapeutic approach.
I was just quite curious about the devices that you prefer to use for the triple therapy that you were talking about.
Yeah, look, I think it depends a little bit on how the patient has come to you and whether they've, when I say that, how they've got to the stage where they've got uncontrolled symptoms or still suffering from exacerbations. If you think that this patient is somebody that might long-term benefit from lower dose of inhaled corticosteroids, you may go for a LABA-LAMA single inhaler and then use the inhaled corticosteroid as the alternate inhaler. That does give you a dose titration option, although the benefits of that in COPD have also been debated, but it makes it a bit easier to stop and start therapy. The other aspect to that then, or alternative, is to use a long-acting beta agonist with an ICS combination, the sort of traditional combination and then adding in a sort of PRN LAMA therapy. And you might do that for somebody who's having occasional exacerbations but are not troubled by so many symptoms. I think it comes down to patient preference. I think it comes down to your preference and probably comes down mostly to the patient's capacity to use that inhaler with the greatest and best technique.
This is a very busy time for general practice with regard to COPD. I think the more we can sort our patients out in the January, February and March, the less work our hospital colleagues will have to do in the winter season. So I think it is a very busy time, pre-flu season, etc. And once again, I thank Rob for your very clear exposition today. That sorted a few things out in all of our minds, I'm sure. Thank you again.